shall continue on with practical 2, and as usual I will start my I will share my screen. Okay, all right, can you see it?
Yes, Doctor.
Okay, all right, so without further ado, let's start. Okay, so this time we're going to cover some of the pathology in the accessory organs. Right. So can someone highlight to us the important points in case 1?
May I, Doctor?
Sure. Sorry, you are?
Rina.
I'm Rina. Okay.
Okay, an elderly 63-year-old man with history of chronic hepatitis B presented with massive hematemesis, jaundice and distended abdomen, and outlying at the resuscitation bay.
Okay. So what's the relevance of, can you sort of tie things together, like why, how can you tie in some of the presentations with his with the underlying history at this point in time, like even before you see the macroscopic and microscopic and the rest. So what do you make up from this piece of information, Amrina?
From what I understand, he already had a liver problem because he had a known history of chronic hepatitis B.
So the hepatitis B is not an acute hepatitis. Okay, it is a chronic hepatitis. Okay. Okay, and from your understanding, what could be the cause of his? Is there any relationship between the chronic hepatitis B and hematemesis? Yes, yesterday we discussed about hematemesis, just to make sure that you understand the word hematemesis again. So what is it, Amrina?
Hematemesis is blood vomiting. Is that right, Doctor?
Yes, correct. Okay, so do you know the relationship between hepatitis B and hematemesis? Not just a small amount of hematemesis, but this is a massive hematemesis.
I'm not sure about that part, Doctor. Sorry.
Okay, all right. So how about other things, like other examination findings? Can you sort of make some comments to why the patient, the relationship between all this information? Why is it jaundice? Why was his abdomen distended? What do you think is happening to this patient?
Liver failure, Doktor.
Liver failure? Ni siapa ni?
Hannah.
Hannah. Okay, Hannah, what do you mean by liver failure?
Liver failure means maksud macam sebabkan dia dah ada hepatitis B. So massive hematemesis tu mungkin boleh relate dengan co-infection disebabkan hepatitis.
Co-infection?
Macam infection.
Another infection, you mean?
And then jaundice, maybe dia ada liver failure. Yang distended tu maybe dia punya liver enlarged, macam tu lah.
Okay, all right. Thank you for your offering, Hannah. Okay, we'll go through in more detail in the rest of the practical. But can anyone sort of suggest any other suggestion from anyone at this point in time, given the history of chronic hepatitis B?
Doctor, can I try?
Sure. Sorry, you are?
Shagan, Doctor.
Shagan, okay.
So, as we know, the patient has a history of chronic hepatitis B, and this infection can lead to liver cirrhosis. And because we can see the patient's abdomen is distended as well, so it can be a sign of hepatomegaly, the patient. And the massive hematemesis, as we learned yesterday, it can be usually due to upper gastrointestinal tract bleeding, usually because it's easier to vomit blood if there's any bleeding there. So since, as mentioned, there's liver cirrhosis, so I think the patient might be having portal hypertension as well, which can lead
Mhm.
to any rupture of esophageal varices if there's any. So it can lead to
Okay.
hematemesis.
Okay, good, good, very good thought process, Shagan. Well done. Okay, so we will go through, as I said, in more detail in the subsequent questionings. Okay, so I just want to see how much you understand by this piece of information. So what happened? So the patient is that severe that the patient collapsed and died in the resuscitation bay. Okay, so so the hematemesis must be very significant, resulting either as a result of the massive blood loss that he developed hypotension, and then he collapsed because of the hypotensive shock, or as you all have indicated, that perhaps it's a sign of liver failure, that the patient died due to that. Okay, so and that's the reason of the autopsy anyway, to find out what is the cause of death. Okay. All right, so just to remind ourselves how does a normal liver looks like. Okay, so can someone just very quickly tell us about the normal anatomy of the liver based on this picture? As I said, I'd like you to integrate the information, the knowledge that you've gained, and applying it to various abnormalities or pathologies. Because if you do not understand or appreciate what is normal, and it is difficult for you to appreciate what is abnormal. Okay, so can someone just very briefly, I'm not an anatomist as well, but just to get someone to just tell a little bit of normal liver.
Doctor, may I try?
Sure, sure. And you
Okay,
are?
so my name is Ajay Fidos bin Zaman.
Okay, Azri.
Okay, so in terms of color, it's reddish in color, and it is divided into the right part of the liver and the left part of the liver. Is that right? So we can see that the right part of the liver is slightly bigger than the left part. Is that right?
Okay, you tell me. You've done your anatomy, right? You should know more than me.
What else should I describe? So
what is this structure here? Tak ingat lah.
Tak ingat. Apa itu?
Tak ingat.
Vesiform ligament.
Oh, it's ligamentum teres, is it?
Tadi ada orang sebut tadi apa tadi? Falciparum.
Falciform ligament. Okay, sorry.
Okay. Alright.
Falciform ligament.
Apa? Okay, and what is this structure here at the back?
Is that the inferior vena cava?
Betul?
That's the inferior vena cava. Lepas tu belah atas tu ada coronary ligament.
Okay, alright.
Okay. And then below the right lobe ada gallbladder. Itu je.
Okay, which kita tak nampak lah, tak sure yang ni adalah gallbladder ke apa kan. Okay, but this is from the anterior aspect. Okay, good. So when we do autopsy, usually we need to know what is the normal size and the normal weight. Then we can make some sense. Is there any problem, and is there any abnormalities based on the size and the weight? Okay, so the normal liver size for women is about 7 centimeter. And for men, it's about 10.5 centimeter. So the liver span 2 to 3 centimeter larger or smaller than these values are considered abnormal. Okay, so usually we would, during examination palpation, we would want to know whether there's increase or decrease in the liver span. Okay, so there's some estimates based on how you examine the patient. All right, but this is the normal liver size, and the normal liver weighs 1.2 to 1.4 grams in adult women, and 1.4 to 1.5 grams in adult men. So depending on the pathology, it can be increased or reduced. Okay, so yeah. So let's have a look at this. This is the normal structure. Can someone recap your understanding or your knowledge of normal liver structure? Okay, saya panggillah Zulaika.
Yes, Doctor, can you hear me?
Yes, I can.
Okay. So based on the picture, we can see the we can see the nodules.
Nodules.
Yes. Maybe we can see the gland there. Is it gland, Doctor?
Which one is gland? Is this okay? First thing first. Is this normal or abnormal?
I think it's normal, Doctor.
Okay, normal. What constitute normal liver histology? Apa yang ada? Ada glands ke? What are these cells here? What happened? Liver
hepatocyte, yes, okay.
Hepatocytes, okay, so it's the liver cells in the layman's term, call it liver cells. In medicine, we call it hepatocytes, okay, in histology, we call it hepatocytes. Okay, in between the plates of hepatocytes, then these are the sinusoids, kan? Okay, so liver is dia ada a particular architecture, betul? Dia ada architecture whereby the architecture of the liver is very important because this ensure that it will carry out its normal function. Okay, one of which is very important is apa yang important. When I label 1, 2, 3, does anyone know what am I referring to and why is it important?
Is it the central vein, Doctor?
Okay, 1, 2, 3 is not the central vein. Where is the central vein?
Yang warna putih tu bukan?
The white color.
Cakap mana? Atas, upper right, upper left, lower right, lower left?
Ni ada 3, Doctor.
Ni ada number 3.
Okay, sini. Okay, so upper right hand corner. Okay, so, yep. So this is the central vein, betul? So, 1, 2, 3 ni kenapa? Kenapa ada 1, 2, 3 ni? What is it? Dah belajar kan histology? Ini bukan subjek histology ni practical pathology. Saya just nak recap your understanding of normal histology of the liver parenchyma. Okay. So ini apa ni structure ni? Okay, kalau ni central vein, yang ni apa?
Is it for the triad?
Portal triad or portal tract. Okay, good. So what is the three components in the portal tract?
One of it is bile duct.
Okay.
Hepatic artery, if I'm not mistaken. And also portal vein, doctor.
Portal vein, yes, correct. Okay, so we have the portal tract and we have a central vein here, and in between are the hepatocytes and the sinusoids. Okay, so what are these numbers referring to then? In what direction is the flow of the blood?
From 1 to 3, doctor.
Yes,
From
from
zone
1 to
1.
yeah, so zone 1, zone 2, zone 3. So then it dumps the blood dumps into the central vein, and where the central vein goes to?
Inferior vena cava.
Yes, it will then this is just one central vein, but there are many which then gather and dumps the blood into the inferior vena cava. So so that is the importance of 1, 2, and 3. If there are any abnormalities of the liver parenchyma, whereby this architecture is disturbed, okay, like the case that we have for case 1, then the blood flow cannot move freely from the portal tract to the central vein. When it cannot do that, then it will disturb the major function of the liver. What are some of the major functions of the liver?
To produce the bile.
Okay, producing the bile. Okay, lagi yang lain?
To break down red blood cell, doctor.
Okay, break down red blood cells.
Storage for glycogen.
Storage for glycogen. Lagi?
Detoxification of drugs.
Detoxification of drug metabolites. Okay, good. Lagi?
Protein synthesis.
Protein synthesis. What are some of the important proteins?
Albumin, doctor.
Albumin. Lagi?
Liver enzymes.
Okay, liver enzymes. Lagi? In terms of blood clotting mechanism?
Liver produce TPO hormone for platelet production.
Okay, platelet production and blood clotting proteins lah, kan, blood clotting proteins. Okay, and tu you all tak belajar lagi lah, but just as a principle, they also produce blood clotting proteins. Okay, those are some of the major functions of the liver. I mean, why am I, emphasizing on the normal of liver? Because unless you can really understand the normal function of the liver, then you will not be able to appreciate what the abnormalities that will happen to the liver and the consequence of these abnormalities. Okay, so I want you to really understand that concept, the histology, as well as the normal physiology of the liver. Okay, so as you mentioned, this is the portal tract, and it consists of the portal vein. Okay, and there's the bile duct, and there's also the hepatic artery. On the other end is the central vein. Okay, and the blood will move from the portal tract to and drain itself into the central vein. Okay, and in between the sinusoids, in between the liver cell plates. Okay, so this is the case that we have. Okay, so can someone tell me what do you see in this macroscopic image?
Can I try, Doctor?
Sure. And you are?
Abirami.
Abirami, okay.
So we can see a nodular surface which gives a hobnail appearance due to the scattered nodules, and I think it can be due to the fibrosis.
Okay, all right. So is the nodules small? Are the nodules small or is it large?
They are small and
small. Okay, and are the nodules diffuse, like involving most parts of the liver, or is it only a particular segment of the liver that is involved?
It's in the whole of the liver.
Yes, it's involving quite diffusely, involving almost all parts of the liver. In fact, we can't appreciate the normal looking component here. Okay, good. Any other things that you notice, Abirami?
It looks more greasy, brown.
Okay, so some greasiness. And how about the coloration of this area?
It looks a bit brown.
Brown, and do you think there's a tinge of like greenish tinge in this area? Okay.
Yes.
All right. So why do you think there's some greenish discoloration? What could have accumulated?
Is it due to the necrosis?
No, not really. Okay. So, anyone?
Doctor, is it bile?
Okay, bile. Yeah. So perhaps there's some accumulation of bile, or what we call cholestasis. Okay. And as I said, I mean, sebab dekat dalam liver pun dia ada intrahepatic bile ducts, and then dia ada extrahepatic bile ducts, which all then drains to the common bile duct and then release into the system. So if there's any problems with the liver, the bile can also accumulate. Other than the hepatic enzyme race, the bile also can be accumulated. Okay, good. So there are two types of nodules. The smaller nodules, which we call it micronodules, and usually it's less than 3 millimeters in thickness. I know there's no scale here, but these, as mentioned by Abirami, these are small nodules. Okay, and the larger nodules, more chunkier nodules, those are macronodules, and it's more than 3 millimeters in thickness. Okay, so basically, as what Abirami has pointed out, all these are the micronodules involving almost the entire liver, and it is regenerative nodules. Okay, regenerative is actually referring more to the microscopic image, but we can also say that these micronodules are due to some regenerative process, menyebabkan otherwise the liver would have been smooth. Okay, but because of the regenerative process, then these micronodules develop. Okay, and it is involving the entire liver. Okay, I mentioned about macro and micro nodules. Okay, and the slightly greenish discoloration due to the accumulation of bile. The size, we expect it because of these micronodules, as I think Abirami also mentioned that these nodules may be due to fibrosis. Okay, so fibrosis in layman, what what is the layman the term fibrosis to a layman, dia akan panggil apa, ataupun kita nak explain to a layman, kita cakap apa?
Is it scarring, doctor?
Yes, scarring. Okay, senang untuk kita nak faham, kita sendiri nak faham dan kita nak explain pada orang. So it's actually scarring. So the structure of the liver has been scarred. So what happens to a scar? The scar will retract, isn't it? So kalau kita ada wound on our hand, for example, when it heals, then it will retract. So the area too becomes retracted. Okay. So that this is not just one part of the liver that is healing, but or scarring, but there's the entire liver is scarring. So they will be retracted. So when it's the liver organ is a lot of retraction because of the underlying fibrosis or scarring, then it will lead to shrinkage in the size of the liver. Okay, especially at the more established phase of liver cirrhosis. Okay, all right, good. So can someone just add on to what has been mentioned by Abirami? Anything else you want to add? So I think we can appreciate here that there is a scale, and the scale shows that those are micro nodules. Most of them are less than 3 millimeters in size. Okay, and it's a lot. So this is a section, they slice through a part of the liver, and we can see this part of the liver appears apa? Tadi Abirami pun ada mention tadi, it appears yellowish and fatty. Okay, all right. So there's some fatty changes occurring in the liver as well. In the background of all these small nodules. Okay. Okay. So let's move on to the microscopic image. So the same. Yes. Sorry.
Doctor, sorry. For the previous photo tu, can you say about the falciform ligamentum?
You mean like this?
Compared to the normal one, the previous, the first one, yang new one, and this one, kan for the normal kita boleh appreciate the falciform ligamentum, but for this one there langsung tak ada.
Maybe not significant. I'm not sure about how they where has the falciform ligament gone, but whether they have dissected it. But good point, but I am not sure, to be honest. I think it's the way that it's been dissected. It shouldn't have affected the ligament in such a way lah, due to this condition. Okay, but yeah, good point. Maybe you want to just look up. Yeah. Okay. Alright, so siapa nak tell us about this microscopic image? Okay, Shweta. Shweta?
I'm sorry, doctor. I think Shweta left this meeting just now. Maybe she doesn't have.
Oh, okay. How about Sharifah Rokaya?
Yes, doctor.
Yes.
Okay, I try. From the pictures, I can see that there is a bridging fibrous septa that separates the hepatocyte into nodules. And then there's a diffuse disruption in lobular architecture of the entire liver. And then the presence of medullary bodies.
Can you see that? Maybe not at this power, this magnification lah kan. You can't see the mammillary bodies at this magnification. That's just textbook description, isn't it? But yeah, maybe in high power view, we may be able to see the mammillary bodies. Okay. Okay, good. So do you think the architecture is preserved? Or do you think the architecture is disrupted?
I think it is disrupted.
Disrupted, okay. Can we see anywhere the presence of portal track? Tak nampak kan? Kita tak nampak portal track, kita tak nampak kat mana portal vein, kita nampak the hepatocytes, okay. As you mentioned, apa tu, regenerative hepatocytes lah in nodules with intervening fibrosis, okay, and some this area maybe some inflammatory cells, okay. All right, good. Okay, so I hope we have all understood and agreed that there is loss of the normal lobular architecture of the liver, okay. So whereby we see these nodules, okay, we saw the small nodules in the macroscopic image, in the gross image of the liver, okay, and these are actually what what the nodules are under microscope, okay. So, and there's another one up there which I didn't circle, okay. And so these are the regenerative nodules of hepatocytes, okay. So the hepatocytes supposedly, kalau kita nampak, kalau kita tengok tadi the normal histology, it should be widespread hepatocytes without any intervening fibrosis. It's just like full of hepatocytes, and you see portal tracts and central vein in a very organized manner, but not in this condition. Okay, so the hepatocytes are in nodules, and they have these blue things in between the nodules of hepatocytes. Okay, and not only in between the larger nodules, but in the nodules itself, there's area also having these. Okay, and these are actually the fibrocepta, the fibrosis, interconnecting fibrocepta. Okay, so these are the fibrosis that has occurred in this condition, leading to the disruption of the normal architecture of the liver. Okay. Kalau tak, dia tak macam ini kan. This is because of this condition. Alright. So so having this microscopic feature, so what is the term for this? What is the microscopic interpretation of this condition? So what do you say at bottom line? So what does it confirm? What is it?
Liver cirrhosis.
Yes, liver cirrhosis. Okay, so this is liver cirrhosis. All that we have described is referring to an interpretation of a liver cirrhosis. Okay, so in other words, the liver has underwent a healing and repair process in the form of fibrosis, which leads to the disruption of the normal architecture, and these are all tied down to liver cirrhosis. Okay, good. All right, so just any additional justification to say that this is liver cirrhosis other than the microscopic image?
Can I try, Doctor?
Sure, sure.
My name is Asmisa.
Okay, Asmisa.
Because from the clinical presentation of the man, it showed that he has history of chronic hepatitis B, and usually hepatitis B can proceed they progress to liver cirrhosis. And we also have jaundice, but the most reason yang kuat hepatitis B lah.
Mm-hmm. Mm-hmm.
The microscopic and macroscopic reason just now.
Okay. All right. So yes, the chronic hepatitis B is definitely very important because that is the most likely etiology. I mean, there are many other causes of liver cirrhosis, but the most apparent that and most likely in this case is due to chronic hepatitis B infection. Okay, so the examination shows that there's jaundice and ascites, okay, with the diffuse nodularity and the shrunken liver and the architecture that we have described just now. Okay, good. So other than chronic hepatitis B, what are the other possible causes of the diagnosis?
Can I answer this question, doctor?
Sure. And you
Okay,
are sorry?
my name is Haris.
Haris, okay.
Haris, okay. Okay, for other possible causes, can be chronic alcohol abuse, and then can be any syndrome like allergic syndrome, which is newborn born with lack of bile duct, so they will produce less bile. Okay, and then it can be also due to obesity and also diabetes. I think that's all.
Okay. Anyone else would like to add on to Harith possible causes of liver cirrhosis? Okay. Tak ada. Okay. So alcohol is definitely one of the major cause of liver cirrhosis worldwide. Okay, so the alcoholic liver cirrhosis is due to the effect of the alcohol itself. Okay, so I wouldn't want to go through in detail of the how alcohol's metabolism then leads to the liver cirrhosis. Okay, you can find that out. Okay, so and there are other non-infectious causes of hepatitis, for example, autoimmune hepatitis or any metabolic causes of hepatitis. Just now you mentioned about the Crigler-Najjar syndrome. That's a condition that you get in the newborn where they have problem with the bile duct. So bile duct, biliary diseases can be a primary problem of the biliary tract or is a secondary biliary cirrhosis. Okay, so any biliary diseases. And then Wilson's disease, whereby, does anyone know what is Wilson's disease?
Is it excess copper that's stored in the liver?
Yes, so the excess of copper will then injure the liver parenchyma. Okay, so hemochromatosis, tadi ada mention ke hemochromatosis, tak ingat? Okay, so what about hemochromatosis?
Iron, doctor.
Iron, okay, yeah. So excess of iron. So this can be due to either a primary problem with the iron metabolism, or it can be due to secondary cause, like someone who has been taking a lot of blood, have been receiving a lot of blood, for example, patient with hemophilia, thalassemia and all that, so they get a lot of liver blood, receive a lot of blood lah. Okay, so hemochromatosis, and then the other one is alpha-1 antitrypsin deficiencies. So all these are the possible causes of liver cirrhosis. Okay, so in this case, what is the pathogenesis?
Doctor, can I try?
Sure, sure.
Okay, so basically,
Sorry?
when they, I'm Muhammad Iman.
Okay, Iman.
Okay, so basically, when the liver they get injured, inflammation will occur. So this inflammatory response will release cytokines, and the destruction of this there will be destruction of the hepatocytes and also the vascular endothelial cells. So this will the chronic form of this inflammation will trigger the process of healing with fibrosis, where it is the replacement of necrotic hepatocytes with the regeneration of new hepatocytes forming nodules, and this will form the fibrous scar tissue, which is the result from collagen deposition by the perisinusoidal stellate cells.
Okay. So by the way, perisinusoidal stellate cells, what are they in principle? What sort of cells are they? Macrophages, yeah? Okay, so as you kalau you can remember your apa tu the basic pathology yang you belajar masa SEM 1 tu, macrophages dia akan activate the collagen formation kan. Okay, so okay, very good, Iman. Okay, so basically in principle, yes, there's in this case the injury is the infection, the hepatitis B infection. So this injury will incite the acute inflammatory process and then leading to initially acute hepatitis. But as we know, not all acute hepatitis will it can resolve, but but it can also persist, and it can become chronic. On another arm, acute hepatitis can be very severe, that one can have a fulminant liver failure. So at the first instance that they have the infection, it will be so severe that the patient, will sustain a fulminant, a very severe liver failure and can die because of that. Okay, but most they can have persistent infection and lead to chronic sort of infection or chronic hepatitis. So as you mentioned, there's the healing and repair and regenerative process, and this will then give rise to the collagen deposition surrounding the regenerative nodules of hepatocytes. Okay, and this in turn leads to liver cirrhosis. Okay, excellent. Okay, so the different outcomes of hepatitis B, I'll just show you the different outcomes. So I was mentioning just now that, if you have acute hepatitis B infection, you can recover. You can get a fulminant infection and leading to fulminant hepatic failure, and one can die because of this, or they can have chronic form of hepatitis B, whether it's inactive hepatitis, chronic hepatitis B, or active chronic hepatitis B. Okay, so this will be detected based on the I am sure you have been exposed to the various serological markers, based on hepatitis B surface antigen, hepatitis E, hepatitis BE antigen, envelope antigen, or hepatitis B DNA, and various other markers. Okay, all right. So another representation to understand what is the outcome from acute infection. I mean, the majority is subclinical disease, then they can recover. Okay, so the acute infection occurs in and leading to acute hepatitis is about 1/4 of the cases, where most recover, and some of them become fulminant hepatitis and die. Some will persist and becomes healthy carrier, and about 4% will have persistent infection leading to chronic hepatitis, and about a quarter to a half of the cases will develop cirrhosis. Some will cause death because of the cirrhosis, the complications of cirrhosis, and about 10% of the cirrhotic liver disease will lead to the formation of hepatocellular carcinoma, and can also die because of the carcinoma. Okay, and just I don't want to go into much detail about this, but just the various antibodies and antigens, the serological marker in hepatitis B infection. Okay, so just to compare with hepatitis C, so as we know that C is less common compared to B. Okay, so and hepatitis C is less dangerous than hepatitis B in acute phase, but are more likely to go to chronic compared to hepatitis B, and more closely linked with hepatoma, or in also known as hepatocellular carcinoma, compared to B, hepatitis B. Okay, so yeah, so that's just a little bit on the outcome of hepatitis B infection. Okay, so coming back to this case, what is the complication that has occurred that you can, see, or you can appreciate from the information that we have so far? And can you explain the underlying pathogenesis? I think we've touched this a little bit earlier, but just to re-emphasize on this point. Okay.
Okay. My name is Nudia Kalish, and I will just try. So the complication that has been mentioned in the case is hematemesis, jaundice, and abdomen was distended. Okay, itu yang di-mention dalam soalan tu. So basically, 2 of it is mana jawapan saya? Okay. Sorry. Wait, where is it? Okay. Okay. Oh my god, I'm so panic. I don't know. Okay. So in cirrhosis, the scarred liver tissue blocks the blood flow to the liver, right? And this causes an increase in the pressure in the vein that takes blood from the gut to the liver, which is the portal vein, and then the increased pressure pushes back into the gut and causes the vein to swell in the gullet, and this so this is the complication is esophagovaris that explain the hematemesis. And the next one is the distended abdomen, which is SI. It is also due to portal hypertension. The increased pressure in the portal vein causes the fluid to accumulate in the abdomen. And then the jaundice, for the jaundice, the cirrhosis, we know that cirrhosis causes the liver function to decrease, right? So the conjugation of the bilirubin becomes low, and therefore the secretion of conjugated bilirubin into the bile duct canalically also decrease, and the drainage of conjugated bilirubin out of the ducts also will become low, leading it to jaundice. So yeah.
All right. Thank you very much, Nadia. It's a very good explanation. Okay. So the main complication that has occurred in this case is the esophagovaris, as you have pointed out. The rest too are the part of the symptoms and sign of the chronic hepatitis B. I mean, as a result of liver cirrhosis. But what happens thereafter, as a result of the liver cirrhosis, is the esophagovaris, as you have explained just now. Okay, whereby we have the portal hypertension, the liver cirrhosis menyebabkan the shunting, because it cannot go through the liver anymore, so it shunts, it goes into another direction, and this other direction of circulation is very fragile, and it can dilate and it can rupture. So it can rupture in one of the area is the submucosal vein, which is at the gastroesophageal junction. So when this rupture, then one can vomit out massive amount of blood, or massive hematemesis Okay, so and this is not the only manifestation of portal hypertension. We'll go through other complications of portal hypertension after this. Okay, good. So other than esophageal varices, what other possible complications that can happen in
Doctor,
patients?
can I answer this?
Sure, sure. And you
I
are?
am Elisa.
Elisa, okay.
Okay, so list other possible complications of diagnosis in 1.3, which is cirrhosis. First is splenomegaly. Following the portal hypertension, blood backs up to the splenic vein and causes congestion of the spleen. This increases blood cells trapping within the spleen and causes pancytopenia. Pancytopenia, sorry. Okay. And then next is encephalopathy.
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 Okay, that's fine. That's fine. No problem.
And which is a degeneration of neurological function, which leads to confusion. This is because the low liver function makes the liver unable to remove toxins from the body, and toxins will build up, which causes the
encephalopathy.
Encephalopathy.
Yeah.
Okay, and then last one is hepatocellular carcinoma, in which the cirrhosis increases the risk of developing the hepatocellular carcinoma.
Okay, all right. Okay, thank you very much, Eliza. A very good explanation. Any other possible complications? Anyone else have? Okay, tak apa. So kita ada tadi complications related to portal hypertension, and kita dah mention about the esophageal varices, and then you mentioned elaborated further on the splenomegaly and the effect of splenomegaly. So as the name splenomegaly, spleen, and it's megaly, so the organ is enlarged. So you can have in general organomegaly, any organs that is enlarged. You can have hepatomegaly, you can have hepatosplenomegaly, or anything. So basically megaly is the enlargement of an organ, in this case spleen. Okay, so because of the pressure buildup, so and one of the major function of the spleen is the production of, or the breakdown of, the red blood cells. So because of the increase in the liver, the spleen, so you can get destruction of the various cells, okay, including, so you get all the cell lineage is disrupted, is being distracted. So you get pancytopenia, means that your hemoglobin is low, your white cell is low, your platelet is low. Okay, so that is the result of splenomegaly. So the ascites, as described just now, and the hepatic encephalopathy. All right. So the what is some of the manifestation of encephalopathy? Does anyone know? How does encephalopathy manifest? How is the patient usually? Are they alert?
Confused.
Yes, they're confused, and they can, if it's severe enough, they can enter coma. Okay, so they can be totally unconscious. Okay, because of this accumulation of the ammonium and various other toxic substances. Okay, all right. And then you can have the progressive liver failure. So banyak lah. So just now, why I asked you in detail what is the function of the liver, because you need to understand the function of the liver for you to appreciate what will happen if there's dysfunction of the liver, or in other words, liver failure, the liver failed to perform its function. So progressively, because of the cirrhosis, the liver will slowly dysfunction and fail. Okay, when the liver fails, and that's the the time that it's will have a high mortality, or can lead to death. Okay, and then as mentioned, the hepatocellular carcinoma, though just now we saw that 10% of liver cirrhosis, only 10% of the liver cirrhosis can eventually lead to hepatocellular carcinoma. But yeah, it is a complication nevertheless. Okay, so these are the other clinical features of chronic liver disease, right? So okay, basically the features can be due to the effects of the liver failure, okay, ataupun it can be the effect of the portal hypertension. Just now you have described about the esophageal varices, okay. Remember, when there's upper GI bleed, so not only you get hematemesis, you can also get melena, right? So then we elaborated on splenomegaly, okay. And then the abdominal veins, the dilatation of the abdominal veins, which we call caput medusa. I have a picture of caput medusa here. Okay, so this is what caput medusa looks like. Okay, so this is one of the effects of the portal hypertension. Okay, so the blood is not able to pass through the liver, and then all the other veins prior to it will dilate, so including the abdominal veins. Okay. So okay, so we have the ascites again. In combination with the back pressure as well as the function of the liver to produce albumin. So hypoalbuminemia will lead to the low oncotic pressure, so the fluid will accumulate in the third space. Okay, so which is one of which is the liver, I mean the peritoneum, so you can get the ascites. Not only the abdominal veins is dilated, but you can also have dilatation of other veins like varicose veins or rectal veins. Okay, so rectal vein dilatation or rectal varices is what is known to us as hemorrhoids. Okay, so that can be one of the manifestation of portal hypertension. Okay, so we need to, because we have understood, hopefully we have all understood in good terms, the liver, normal liver function. So because of this condition, we should be able to relate all these clinical features because of the dysfunctioning liver. Okay, so mentioned just now about the coma because of the encephalopathy, yeah, because of the accumulation of the toxic metabolites, right? And then this fetal hepaticus. Fetal hepaticus is also because of, does anyone know what is fetal hepaticus? It's mentioned here, but what is the cause? So
I'm not sure, doctor. It's my first time hearing it.
okay, all right. So anyone knows what is the reason for fetal hepaticus? It's also due to the accumulation of toxic metabolites lah. I can't remember what particular is it urea or ammonia or something like that. Okay, so that result in the patient's breath. So when you examine the patient, not only that you observe, but you also, there is a particular smell if someone has this chronic liver disease. Okay, this fetal hepaticus. Okay. Other than that, they can have spider nevi, gynecomastia, loss of sexual hair, testicular atrophy. What else? This here, palmar erythema. Do you know what all these things that I mentioned just now? What is it related to?
Clinical features of chronic liver disease.
Okay, yes. But what particular function of the liver that is disrupted that leads to this? Spider nevi, gynecomastia, loss of sexual hair, testicular atrophy, palmar erythema. bottom line? What is the problem there?
Hormone, doctor?
Hormones, yes, correct. So it's related to the hormones, whereby normal liver should be able to break down and remove excess hormones. So in the case in these cases, it's related to in particular estrogen excess. Okay, so when there's estrogen excess, you can get the spider nevi, gynecomastia. Basically, in a man, you shouldn't have saggy sort of breast, but there's like breast formation in males. So this is what we call gynecomastia, and this is because of the excess in the hormone, estrogen hormone, because they're not able to be broken down and removed by the liver cirrhosis, as the cirrhotic liver. Okay, same with loss of sexual hair and testicular atrophy. This is also because of the excess in the estrogen hormone, and I mentioned just now, it's not stated here, is the palmar erythema. Okay, so again, the excess of hormone, so you can get redness of the palms of the hands. Okay, and then there's also other things we mentioned about the jaundice. Okay, ascites you have mentioned as well. Okay, liver flap or liver flap. Does anyone know what is the cause of the liver flap?
It's due to the encephalopathy, right, doctor? Like,
yeah, it's part of the it's part of the feature. I mean, it's related to encephalopathy, but it is a manifestation. We call it. I mean, it's part of the findings with encephalopathy. So encephalopathies, it is due to the toxic accumulation, either urea or ammonia or all the toxic metabolites. Okay, when they are in excess, then they will have the liver flapping. Okay. The cause and tremor. Okay, I mentioned just now earlier in the normal physiology of the liver, is one of it is the production of proteins. So one of the important proteins that is supposedly being produced is the prothrombin. Okay, so now when the liver is dysfunctional, so decrease in prothrombin is made, so one would have bleeding tendency. Okay, so the bleeding tendency can they will bleed more easily lah. Okay, and ankle edema is related to the low protein, like low albumin and all that, giving rise to ankle edema. Okay, so I hope you can, at this point, you can start to appreciate better the normal structure and function and the manifestation of its clinical features and the complications that we are seeing. Okay. Okay, so this is just a summary. You can have a look at it in your own time. Some of the major functions of the liver, right? So this is what we call a spider nevi. It looks like spider, isn't it? So you can see the spider nevi on the upper chest. Okay, so this is because of the estrogen excess. Not only liver disease, but like pregnancy can also result in spider nevi. Okay, this is the palmar erythema. So again, related to the excess estrogen. Okay, and this was the carpet medusa that I was mentioning earlier. Okay, the dilated abdominal veins. Okay, so any questions regarding case 1? Okay, so it's quite an elaboration and correlation between normal and abnormal for case 1. We've discussed for about 1 hour just on case 1 alone. So I hope, as I said, you can appreciate and have understood what we have discussed so far. Okay, and being able to explain why the clinical manifestations occur Okay, all right. So second case is probably easy because you've already been exposed to it before this. So I hope this is going to be a quick one for case 2. Okay, but nevertheless, can someone highlight to us the important points in the clinical scenario of case 2?
Can I try, doctor? My
Sure.
name is Nasuha. Okay.
Nasuha.
The lady is 40 years old. She has recurrent right upper quadrant pain and nausea and vomiting, and the pain was aggravated by intake of fatty food. She also has tenderness over the same region where she has the pain. And she has undergone ERCP and cholecystectomy.
Okay. Okay, when I try to justify, I mean, why this patient is having all these things, try to tie things together, not just highlighting the information. Can you try to explain based on just this information so far?
Okay. So like I think from the region itself, it's right upper quadrant. So we can like narrow down the organs that we can suspect on. It could be liver or kidney or pancreas or gallbladder or some parts of small intestines. And then the lady also have nausea and vomiting. Okay. And then the lady has gone ERCP and cholecystectomy, which indicate that the problem is in the gallbladder. So
Okay.
I suppose
Okay,
yes.
disregard the ERCP first. Okay, up to the history and examination. Okay, so what can you make up?
Um I think again, doctor, from
Just disregard the
oh
last point. Okay, concentrate on the ones above. How can you explain the aggravation by intake of fatty food
oh
and the tenderness in upper quadrant, a
okay.
40-year-old lady? Okay.
I think alright. I'll just say what I know. Okay. Bila dah baca soalan, it's like ada gallstones in the gallbladder. So we know that one of the okay, due to gallstones dia akan menyebabkan obstructions. So dia akan menyebabkan cholecystitis, which is inflammation to the gallbladder. So aggravation after fatty food intake tu, kalau kita dah makan fatty food, dia macam natural response by the gallbladder adalah untuk release bile. So bila dah inflame dah pun, so bila dia contract tu menyebabkan pain. Sebab tu lah macam ada aggravation of the pain after fatty food intake. Lepas tu tenderness tu I suppose it's due to the inflammation as well. Yes, and nausea and vomiting too, like the symptoms that come along with the cholecystitis.
Okay,
Yes.
excellent. Tadi siapa tadi?
Nasuha, doctor.
Nasuha. Okay, excellent, Nasuha. So that's what I'd like to hear, Just express yourself, express your thought, and try to put things together, okay? And try to make sense of the information that you have in front of you. So you need to have, as you progress in the course, you need to have more and more of this analytical process, okay? And being able to integrate all the information that you have, okay? All right, so this is just showing you a normal looking gallbladder. Okay, a gallbladder is actually quite small. Okay, so the location, as you have pointed out just now, that it is just below or just posterior to the liver. Okay, and it will drain into the from the cystic duct into the common bile duct. Okay, so there's nothing abnormal about this gallbladder, so this is normal. Okay, so just also because this one dah ada dia punya tagging. So just to show you, go through with you that the like any other gastro hepato biliary system, we have the mucosa. Okay, and that is the but dia dekat gallbladder ni dia tak ada muscularis mucosa. Okay, terus daripada mucosa tu dia jadi muscularis layer. Okay, and then there is the connective tissue or subserosa and the serosa. Okay. Okay, so we can see that the mucosa is lined by the glandular epithelial cells. Okay, and there are some glands within the mucosal surface, but that's about it. It's just there. Okay, so we don't see the glands anywhere more than that area. Okay, so let's have a look at this case whereby an ERCP had been done. They must have suspected some things in this area. I mean, in the gallbladder, and true enough, when they examine the gallbladder, then they notice these things. Alamak, sorry, dah terkeluar dah semua jawapan dia. Okay, I think sebab kita pun dah pernah discuss case ni dekat PBL and all that, so it's just basically a revision of your understanding of this condition. So in essence, what is the bottom line diagnosis for this patient? I mean, even if we have not seen the microscopic image, so based on this gallbladder which we're seeing in front of us, so what is the diagnosis?
Cholelithiasis, doctor?
Just cholelithiasis?
Cholecystitis secondary to cholelithiasis.
Yes, yes. So there is cholecystitis with cholelithiasis or secondary to cholelithiasis. So do you think this cholecystitis is acute or chronic, or acute or chronic? What do you think is most likely based on the image, based on this the picture in front of you?
Chronic, doctor.
Chronic, okay? Yeah, why?
Sebab the gallbladder tu enlarge. And then
enlarge. Other than enlargement,
the thickened
Doctor, can we say it's chronic sebab dia thickened and thickened gallbladder, so tu macam response to the inflammation. So
yes,
it's chronic.
yes, definitely. So the thickening of the gallbladder is significant. I mean, you can have some degree of swelling and edema in acute process, but usually they're not thickened. They're just like temporarily swollen. But in the chronic cholecystitis, the process is, I mean, the wall is thickened because of the fibrosis that occurs on its wall. Okay, so so here we can normally the wall of the gallbladder is less than 3 millimeters in thickness, and here we can see like 3 to 5 millimeters in thickness. Okay, so this is also one of the important findings in ultrasound. When they do ultrasound, they try to measure the thickness of the wall of the gallbladder to then determine that yes, this is more to chronic cholecystitis. Okay. All right. So, and other than that, that is also important is the location. Not only the stones are multiple, okay, but also we have to note the color of the stones. Okay, what are the two types of stones that we can see in the gallbladder?
Cholesterol stone and pigment stone, doctor.
Yeah, good. And in this case, dah obvious lah kan dekat dalam description saya, but this is cholesterol stone because of
the color and the size.
The color, okay, the color and the size. Okay, so how about the color and how about the size?
it is very yellowish, like in the description, and the size is larger. Pigment stones are expected to be smaller in size, but these ones are very large. Yes,
Okay, good.
and yeah.
And
That's all.
okay. Okay, so as a result of these multiple stones of varying sizes, and a lot of the stones are large, okay, they're occupying almost the entire of the gallbladder. So some of the stones are seen obstructing the cystic duct, and this is very important because this will add on to the inflammation, the enlargement, probably complication by empyema and all that because of the suppurative accumulation. Okay, so the obstruction here is also one of the important observation that we see in this gallbladder. Okay, good. Okay, sorry, ini pun tak buang dia punya. Usually I would leave the description and the markings ni after you have explained to me, but it's okay. So in that case, saya terus bagi tahu je lah. So the mucosa should be retained like this. Okay, in areas the mucosa or the epithelium is denuded, means that the area yang bare lah. Macam you remember our peptic ulcer case yesterday. So we have the ulceration or the denudation of the epithelial lining. So same goes here. All right. So not only that, the glands supposedly dekat mucosa sajalah kan. But now we can see glands which are deeper beyond the mucosa. We can see it in the muscles, in the subserosa. Okay, so these are kalau kita go higher power view, this glands ni is bland looking, means that dia tak ada pun, dia nampak macam normal looking. It's not, bila kita nampak macam our principle of bila ada glands and go beyond the muscularis mucosa or beyond the, I mean, you know, the muscularis propria and all that. So kita fikir, oh, is this malignancy, is this invasion kan? But not in this case. Special in this case, the presence of these glands deeper in the structure, like in the muscularis propria and in the subserosa, is not because of the invasion, but it is because of the chronic process yang sebenarnya these glands ni dia becomes enlarged and it burrows deeper and deeper and deeper. So kalau macam kan ini dia satu section saja kan, sekiranya kita boleh untuk nak tengok benda ni in continuity, sebenarnya benda ni akan at some point dia continuous kepada mucosa yang ke atas ni. Okay, so this sebenarnya in continuity. Ni kita nampak sedikit sampai kat sini, tapi actually kalau kita follow benda ni lagi, sebenarnya dia akan continue kat sini. It's just that the glands tu burrow deeper and deeper and deeper because of the chronic process tu. Okay, so this is what we call Rokitansky-Askov sinus. Okay, this is classical lah for chronic cholecystitis. Okay, so the thickening is due to fibrosis that we see elsewhere, but also the thickening of the muscular layer. Okay, so the muscle layer shouldn't be as thick as this, but it is. This is really thick, so that adds on to the thickening of the wall of the gallbladder. So this is one of the gland. Okay, macam gland ni, tapi this gland ni dia dilated. Okay, and there is a structure within the gland. This cystically dilated glands. Dia ada a pigmented concretion. So something yang very solid that duduk dekat dalam gland ni. So what is this? What is this?
Bile.
This is the bile or the part of the stone tadi itulah. So the stones which are concreted adalah concretion of deposits kan, cholesterol ke whatever. It can be cholesterol, as you said, it can be pigment. So this deposition ni dia akan solidify, concrete, macam concrete. So the word concretion comes from concrete, so dia become solidify, and kita nampak, sometimes kita nampak dia di dalam dilated glands ni. Sometimes you can also see like superficially some evidence of pigmented deposits. So all these correlates lah dengan the presence of multiple stones that we see in the gross or the macroscopic punya specimen. Okay, so this is part of the gallstones lah, in this case cholesterol stones. Okay, pigmented ni meaning bukan pigmented stones, tapi pigmented tu means that dia ada colour lah, which is different than the H&E stain ni. Maknanya dia kat sini macam yellowish to greenish in colour. Okay, alright. So boleh faham tak setakat ni? And then of course, because it's the chronic inflammatory process, you can see some inflammation. Also you can see inflammation here, deeper down. This is some collection of most likely lymphocytes lah. But tapi saya tak ada higher power view. I don't think it's needed lah this point. So but it is a chronic inflammatory process with a lot of this response to the chronic inflammatory process, having the fibrosis and the thickening of the wall, Rokitansky, ascosinuses, and you can see the impacted pigmented concretions. Okay. Okay, ada sebarang persoalan tak berkenaan dengan gambar ni?
No, doctor.
Okay, alright, good. So the diagnosis is chronic cholecystitis with cholelithiasis. Okay. Lama. Okay, so tell me about the predisposing factors in developing this cholelithiasis.
Doctor, may I try?
Yes, sure.
But I'm not really sure. But
okay, tak apa.
Okay, for the predisposing factor, it might be raise in cholesterol, or the patient might have might be obesity, diabetes, and also it could be referred to gender, female.
Female, yeah. So female has a predisposing, is one of the predisposing factor lah. Not only the female, pernah dengar tak the 4Fs? Apa 4Fs? One is female, lagi?
40.
40s, in the 40s, yeah? Fat, okay. So obese, overweight, fat, okay. And the last one is fertile. Okay, so 40 female, 40s, fertile, fat. Okay, so those are the 4 Fs lah, which predisposes to or for one to get gallstone. Okay, and other predisposing factors lah that's mentioned today. Okay, anyone wants to add? That is that you're referring to cholesterol stones, ke tadi?
Yes, doctor.
Yeah, so does anyone know what are some of the predisposing factors to develop pigmented stones? Pigment stones?
Crohn's disease, doctor.
Crohn's disease.
Yes. Inflammation at the inflammation at the ileum part, if I'm not mistaken. So, jangan mak. Tiba cari balik doktor.
Okay. Itu untuk pigment stones. Okay, and anyone else? Okay, tak apa. So these are the other predisposing factors lah. So mention about fat, female, fat, fertile, 40, satu lagi, sorry, the 5F, satu lagi fair. Fair ni they're referring to Caucasians lah. Okay, alright. So the cholesterol stone advancing age or 40 tu kira dah macam mid age lah. Maknanya dia bukannya young. So dia dah 40s and above. Okay, female gender. So on pregnancy, so this refers to the fertility. Okay, and fat is the obesity. Okay, OCP, the oral contraceptive pills, is also I'm not sure what is the mechanism, but it's thought to be one of the predisposing factor to develop cholesterol type of stone. I think we have discussed this in PBL, whereby rapid weight reduction can lead to the formation of stones, okay, and any form of gallbladder spasticity. Okay, some form of inborn error of metabolism, hyperlipidemia can also predispose to getting cholesterol stones. Okay, but 80% of the time, as you know, it is a cholesterol stone, and only minimally that one would develop pigment stones. And pigment stones, what is actually pigment stones? Do you know in essence how does pigment stone develops?
I think it's caused by increase in bilirubin amount, and then it mixed with uh calcium salts. Calcium salt. Yes, and then it
With
forms
calcium
pigment
salt.
stones. Yes.
Okay, yeah. Okay, good. So the increase in bilirubin, like for example in chronic hemolytic syndromes or chronic hemolytic anemia, causes of chronic hemolytic anemias. Okay, so whereby we have increase in the unconjugated bilirubin, kan, right, and then also infection. So hemolytic anemia, hemolysis, and biliary infection are the two most important predisposing factors lah in developing pigment stones. So as mentioned tadi juga, ileal disease like Crohn's, ileal resection, and cystic fibrosis can be predisposing factors for this condition. Okay, so the complications. Okay, tell me about the complications. Okay, can someone tell me about the complications of cholelithiasis?
Can I try to?
Cholecystitis, yeah, please.
Biliary colic, empyema of the gallbladder, pancreatitis, carcinoma, or gallbladder cancer.
Okay. Okay, sorry, you are Shagan, is it?
Cohen.
Cohen, okay. So Cohen, can you elaborate a little bit more? Not just listing, but can you explain a little bit more?
So like pancreatitis happens when this gallstone formation, it will block the secretion from the pancreatitis to go out. So it will cause inflammation of pancreas.
Okay.
And the empyema is due to the first.
Okay.
And the cholangitis is the inflammation of the bile duct.
Why?
Because the path is blocked by the gallstone.
Okay. So why is it inflamed?
I'm not sure of that.
Anyone can help? Cohen?
Doctor, is it because it's like the gallbladder is inflamed, so it spread?
Okay, not Not quite, not spreading from the gallbladder to the bile duct, but as Cohen said, the stones is obstructing the bile duct. Okay, what happens when there is an obstruction? Say longkang kita dekat luar rumah tu dia obstructed. How is the flow? Rain sekarang ni tengah hujan kan, musim hujan. So the air hujan tu, air longkang tu kalau ada obstruction, apa yang berlaku?
Tersumbat, terhenti.
Sumbat, terhenti, slow kan. Bila slow, dia slow lah. Maknanya slowing tu is called stasis. Dia slow dia punya pergerakan. Kan dia mungkin boleh lalu bila stone tu kecil, dia tak fully obstructed, tapi flow tu, the bile flow tu dia akan slow in the bile duct tu. Okay, so bila ada slow, so bila slow like any organ pun, contoh macam another organ, kidney. Okay, kalau ada stones in the kidney or in the ureter, so menyebabkan stasicity, lambat bergerak. Flow tu in the kidney, we're referring to the urine kan. The urine, dia flow dia tak cantik. Sama juga kat sini, but dia referring to the bile. Okay, it's slow. So bila slow, it will predispose to the infection, bacteria to invade the area, and therefore dia akan cause cholangitis tadi tu, inflammation. Okay, boleh faham? Right? So that is the cause of cholangitis lah. Okay, because if it's the cholangitis ni, it can be due to stone. So stone, kalau stone sahaja causing obstruction, it may or may not cause inflammation. But if the stone is obstructing the common bile duct, and secondarily there is bacterial invasion to the area, then it can also cause not just cholelithiasis. Cholelithiasis, faham kan? Cholelithiasis is the lithiasis is stone, so stone dekat dalam bile duct. So not just presence of cholelithiasis, but also secondary infection because of the staticity of the flow. Okay, so leading to cholangitis. Faham ke? Ke term ni macam
Faham doktor.
boleh Okay. Alright, good. Anyone wants to add to Kohan? Okay, alright. So kita selain daripada itu, kita boleh dapat perforation juga. Okay, so like any organ systems, semalam kita mention about peptic ulcer disease, sama juga. Dengan gallbladder pun macam tu juga. Though it's not common, but you can have a degree of perforation if it's really severely inflamed, especially severe acute cholecystitis, so you can get perforation of the whole, the entire wall of the gallbladder, and then the content will be disrupted into the peritoneum. Okay, mention about the empyema, okay, because the obstruction of the gallbladder outlet tu, so dia akan menyebabkan berlaku intense inflammations, so you get pus formations. Okay, sama dengan mucocele juga, because of the same thing, but this time is the clear mucus that continues to be secreted, but there's no infection here. It's just the mucin or the mucus is accumulates and leading to the mucocele. Okay, so this one we mentioned I think most of the groups mention about this as a complication to the gallbladder, which is the fistula formation. Okay, so when there is a degree of inflammation, so the two viscous or the two organs can be nearby, can adhere to one another. In this case, the gallbladder and the small intestine or the ileum. Okay, so when it adheres, so it erodes through the wall from the gallbladder through to the ileum or the small intestine, okay, or duodenum. Okay, and then it will, if there are stones within the gallbladder, the stones can go in through, and then it will enter the intestine, the small intestine, leading to intestinal obstruction. So some call it gastric ileus. Okay, so this is fortunately this is rare, but these are some of the complications that can happen. Okay, so this is some of the diagrammatic representation of what I have explained just now. So it's a very severe inflammation with necrosis. You can get perforation. This is what is this? Anyone knows?
Empyema, pus formation.
Empyema, excellent. Okay, and this is. Ni susah lah kita nak nampak sebab kita tak nampak konten dia, but this is actually a mucocele. Okay, so this was the one that I mentioned to you, the fistula formation, and as a result of the gallstone into the small intestine, so this can result in gastric ileus. Okay, so the other name we can call it cholecysto-enteric fistula. So cholecysto ni is referring to the gallbladder, enteric is the intestine, so dia ada fistula. Fistula is the connection between one organ to another organ. So gallbladder and the small intestine. So menyebabkan stone pass through. Alright. So and the other one is, I mean, this is what we see in the X-ray lah, whereby you have distension of the small intestine because of the obstruction. So dia tak boleh nak lalu, jadi dia distend. Macam kita tutup pipe hujungnya, hujung awal tu dia akan membesarkan. So this is what we see in gallstone obstruction or gallstone ileus. Okay, so yang lain-lain tu we mentioned about the obstructive jaundice due to choledocholitis and stones impacting in the sphincter of Oddi. So you have bowel flow obstruction, so you get jaundice. So part of the obstructive jaundice too, as I hope you know, that the obstructive jaundice, the feature is having pale stools and dark urine. Okay, and then the cholangitis I explained to you just now. So infection of an obstructed biliary tract. So this patient will have the charcoal triad, pain, pyrexia. Pyrexia is demam. Okay, pain, demam, then jaundice. Okay, so this is the triad for cholangitis. If the stone is impacted in the ampulla of veta, then it will cause obstruction to the flow of the digestive enzymes of the pancreas, so it will cause the pancreatitis. Cohen also just now mentioned about carcinoma, but this is rare. Okay, good. So this is the choledocholitis, so the stones obstructing the bile duct. Okay, so this is stone affecting, obstructing the bile duct, but there is also reducing the flow of the bile, so invasion of bacteria. In this case, invasion of bacteria from duodenum. Okay, and here if the gallbladder, the gallstone, it impact at the ampulla of veta. So consequently the pancreas can be inflamed. So this is when you have raised liver enzyme and patients very ill. Okay, and of course your gallbladder carcinoma, which is rare. Okay, so that's all that I have for now. Any question that you have?
Doctor, sorry, I just wanted to confirm, what is a mucocele just now? One of the complications just now, I couldn't understand what's that.
Mucocele, sure. Mucocele is the accumulation of mucus, okay, as opposed to empyema is the accumulation of pus. So mucocele is the accumulation of mucus.
Oh.
Okay, so that is a simple explanation lah. Okay, and then the accumulation of the mucus is because of the obstruction, the mucus is being overproduced and it's not able to be drained out, so therefore the accumulation. of the mucus. Boleh faham ke?
Okay, doctor. Thank you.
Okay. Okay, I don't have anything else to add. And if you don't have any other questions, then we can end the session. Okay, I have a request. Can we take a photo? Is everyone able to switch on the camera? Kalau tak, saya tak kenal you all ni. Nanti bila masuk kampus lagi saya terpinga-pinga. Ni siapa ni?